You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for October 21st, 2022. This week, a major trial in atrial fibrillation ablation, left bundle branch area pacing, finerenone, and perceptions of cardiology. This week, the new New England Journal of Medicine Evidence Journal has published a very important trial in AF ablation. The ERACE AF trial, first author Jan Hu, senior author Christopher Pierkowski, set out to answer the decades-old question of how best to ablate AFib in patients with persistent AFib. The technique tested in their trial was the targeting of low-voltage areas in the left atrium, in addition to pulmonary vein isolation. Now, some brief and oversimplified background. Persistent AFib is different from paroxysmal AFib in that when AF is persistent, it often, but not always, means there is structural atrial disease, say scar in the left atrium that can then act as a geographic and electrical barrier to smooth conduction. Think rocks in a stream. Patients with PAF or paroxysmal AFib or early AFib often have little structural disease, which makes the current approach of PVI reasonably effective because PVI eliminates the triggers, the PACs that initiate AFib. But when there is structural disease in the left atrium, electrophysiologists have always felt that targeting only the triggers, the PACs, would not be enough to reduce AFib, and that's because in patients who have atrial scar, any PAC from anywhere could initiate AFib, which could then be sustained because of the disordered conduction through and within and around the scars. Scar in the atrium is like rocks in a stream, creating turbulence. And now it makes total sense that PVI alone would underperform in patients who have persistent AFib. Now, pause there and just think, whenever you hear the phrase, it makes sense, be on alert for a surprise. So yet, before ERACE AFib, there was scant evidence that additional ablation beyond PVI made any difference in patients with persistent AFib. The STAR AF2 trial found that PVI performed as well as two strategies of PVI plus additional ablation. The recently published DECAF2 trial found that an MRI-guided ablation of SCAR plus PVI did no better than PVI alone. And even more recently, just a couple of months ago, the STABLE SR2 trial, published in JACC EP, found that additional low voltage area of ablation did not improve success rates relative to PVI in patients with persistent AFib. The only two trials that hinted at better results from additional ablation beyond PVI were the VENUS trial of alcohol-based vein of Marshall ablation and the CONVERGE trial of hybrid surgical and EP ablation of the left atrium. But both these trials had small numbers of patients and statistically fragile results. So basically, the Bayesian priors before ERACE AF trials set out to target low voltage areas is extremely pessimistic. Therefore, it would take strong evidence to move the priors. Okay, now to the ERACE AF trial. 324 patients with persistent AFib were randomized to PVI alone or PVI plus substrate modification, which meant ablation that isolates any areas of low voltage. Modern three-dimensional mapping systems that are used every day now allows a voltage map of the left atrium, and any areas of low voltage are felt to indicate structural substrate that's capable of perpetuating AFib. The primary endpoint of this trial was a typical one. It was first recurrence of AFib more than 30 seconds. The surprising result was that the endpoint occurred in 50% of the control arm, PVI alone, versus 35% in the PVI plus structural modification group. This resulted in a hazard ratio of 0.62 or 38% reduction that was highly statistically significant. Now, this result was bolstered by the fact that 75% of patients in this trial had implantable loop recorders, and an analysis of only patients who had ILRs, which are the most sensitive AFib detection monitors, also found significantly less first AFib in the PVI plus substrate modification group. Now, there was a cost, however. The rate of adverse events was 1.8% in the PVI group versus 3.7% in the PVI plus substrate modification group, and the only two pericardial effusions and tamponade events were in the active arm that had more ablation. The authors concluded that their approach of electrically isolating areas of low voltage improved AF suppression. Okay, here are my comments. I love this trial. For decades, we have argued about the best approach to persistent AFib. If there are 5 electrophysiologists on a panel discussing persistent AFib, there have been 5 different approaches. Nobody knows the right approach. And instead of single-center studies or eminence-based approaches like we do this and it works, the authors did what is needed. They randomized patients to 2 strategies. Their trial was investigator-initiated and self-funded. This alone is reason to honor their efforts. Self-funded trials are super hard, and I know this firsthand. I also like their approach to low-voltage ablation. They kept to a systematic approach wherein they isolated the area and confirmed block of the lines that isolated it. For instance, if the low voltage area was on the posterior wall, they isolated the posterior wall, and they used anatomic boundaries to create lines that isolated the area, and then they checked those lines for block. This is so important because it helps avoid post-ablation left atrial flutters. Their supplement offers a clear roadmap on how to do this, and it's likely a very reproducible strategy. But here's the thing. The results are counter to a huge evidence base wherein additional ablation beyond PVI has found to not benefit patients with persistent AFib. So we have to explain how Erase AF works, especially since a similar trial, the Stable SR2 trial, also targeted low voltage areas and found no benefit. So here are some thoughts. Now, curious to me is that only 1/3 of patients in either arm had low voltage areas at all. So that means that the 1/3 of patients with low voltage areas in the active arm, which was 54 patients, had to drive the results. Now, that would be like a drug trial in which only 1/3 of those in the drug arm took the drug. It would have to be a very special drug to move the overall results. This makes me think there's a strong possibility of performance bias. Totally unintentional, totally not nefarious, but bias. Specifically, it's possible that there was better quality PVI in the active arm. Now, one logistical reason of that might be that to do structural modification, you're doing it after PVI. That leaves time to go back and check the PVs and touch up the PVI. Thus, you ensure better PVI. Now, one way to test whether pulmonary vein isolation was better in the active arm would be to observe the results of patients who only received PVI in both groups. You'd expect similar results. So in figure S5, panel C, the authors present results of patients who had no low voltage areas and hence only got PVI in both arms. There was a strong trend towards less atrial fibrillation in the active arm. That at least suggests that operators did better quality PVI in the active arm. Now, there was also a bit of balance issue. Table S2, supplement 2, shows more areas of low voltage in those assigned to the PVI-only group. And in all the defined areas, except the septum, the extent of low voltage area was greater in the PVI-only group. Now, this probably occurred simply because there were small numbers of patients in the trial. But if low voltage areas are predictive of more atrial structural disease, the PVI alone strategy could have included sicker patients who were more likely to recur. So in sum, this trial is a great first step and a hearty thank you to the Erase AF authors. It's amazing, and they've set an example of what we should be doing in EP. This data informs, I think, the next trial, which I would definitely require before changing to a more aggressive ablation strategy, especially considering the doubling of the rate of complications in the active arm here. In the next trial of low voltage ablation, we could include more patients, more centers, and importantly, randomize patients further down this pathway. The problem with Erase AF is early randomization dilutes the groups with patients who don't even have low voltage areas. If you randomize A, only patients who had low voltage areas, and B, randomized after pulmonary vein isolation, you would isolate the effects of ablating the low voltage areas. I would also want to see in the next trial ILRs in all patients, and then comments about AF burden rather than 30 seconds of AFib. Okay, next topic, left bundle branch area pacing. FDA has now labeled a special lumenless pacing lead made by Medtronic specifically for left bundle branch pacing. This is the 3830 lead, but its number is not important. I highlight this story for two reasons. One, regulatory, and one, specific to the procedure itself. Regulatory-wise, the FDA approval highlights an important concept regarding use of approved devices. This 3830 lead has been on the market for years, first used in pediatrics. We then used it in His bundle pacing, and now left bundle branch pacing has nearly completely eliminated His bundle pacing. The approval was based on both observational and RCT data from multiple countries. I covered the largest of those, the MELO study, presented and published by Marek Jastrzębski on the April 21st TWIC podcast. The most recent RCT data came from a Chinese group, first author Yao Wang, published in JACC in September. This was a 40-patient trial which found that left bundle branch area pacing compared favorably to CRT for surrogate markers such as left ventricular ejection fraction and BNP. I felt good about the use of this device outside of approved indications because with each step, His bundle pacing, then left bundle branch pacing, we generated reasonable evidence of safety and efficacy. Now contrast that with the Lariat device, an epicardial closure device of left atrial appendage occlusion. This was approved with a very lax 510K clearance pathway, predicated on demonstration of substantial equivalence with existing devices. This was substantially equivalent to suture placement during other types of surgery. And of course, the Lariat device is far from a simple suturing device. Observational data found that there was a significant rate of complications with this device, and then a recent randomized trial found there was no significant benefit. But the only real implications for the FDA stamp of approval of the 3830 leads for left bundle pacing means Medtronic can launch educational materials and programs on left bundle branch area pacing. Of course, the U.S. is different from Europe. I just got back from Italy and Poland, and their industry sends left bundle branch pacing experts to visit centers and help get operators up to speed. Another important reason to highlight this approval is that the 3830 lead is special. It's different from a standard pacing lead. It's low profile, thin, it has no lumen, and no need for a stylet. This may be important because when you put a lead in the septum, there's a little bit of a hinge point that you see. Heart Rhythm Case Reports has published a case report of a conductor failure of a standard stylet-driven pacing lead in the left bundle branch area. JCE, Journal of Cardiac Electrophysiology, also has a report of 2 cases of fracture of standard leads in the left bundle branch pacing area. There's also plausibility here. To do left bundle branch pacing, you have to bury the tip of the lead in the septum so as to capture fibers of the left bundle. That creates that hinge point, which can even be seen on fluoroscopy. Now, the 3830 lead may, emphasis on may, be more suitable for this approach. The thing is now, though, there's intense excitement amongst implanters for these narrow QRS pace complexes, and other pacing companies have been intensely interested in promoting their leads for this procedure. Yet all of the data published comes from the 3830 lead, which is substantially different from standard pacing leads. I'm a medical conservative for all things, but I'm a religious level medical conservative when it comes to pacing and defibrillator leads, having been burned so badly with adapting new and improved leads. The entire space of conduction system pacing needs more data. I spoke to a number of CSP docs in Poland, an epicenter for this procedure, and none were using standard pacing leads, only the 3830 leads. I have no financial conflict of interest with Medtronic, and I plan to keep it that way. All right, next topic. Finerenone is back in the news again. JACC Heart Failure has published yet another post-hoc analysis of the seminal trials of the drug Finerenone, which is a selective, non-steroidal mineralocorticoid receptor antagonist that was approved in 2021 by FDA to reduce the risk of GFR decline, end-stage kidney disease, cardiovascular death, MI, and heart failure hospitalizations in patients who have CKD associated with diabetes. Now, the FDA approval was supported by 2 placebo-controlled trials of Finerenone. First, Fidelio DKD found a significant 18% reduction in CKD progression events and a 14% reduction in cardiovascular events with Finerenone compared with placebo in patients who had CKD and diabetes. The Figaro DKD trial demonstrated a 13% reduction in the risk of the primary composite endpoint of cardiovascular events with Finerenone versus placebo, and again, patients with CKD and diabetes. Now, before I tell you about the recent meta-analysis of these 2 trials, I want to make 2 important points regarding the seminal trials with Finerenone. First, both of these trials compared Finerenone to placebo and did not have a spironolactone arm. This is crucial because the mineralocorticoid receptor antagonist spironolactone cost pennies compared with Finerenone, which I looked up and is listed at $600 per month. So yes, Finerenone is a non-steroidal MRA and it may be better tolerated, but gosh darn it, it would have been good to know how it compared to spironolactone. Second point to make about the Figaro DKD trial, which had CV outcomes as its primary, was yes, it was technically positive, but the 13% reduction in the composite endpoint was driven by a 1.2% absolute risk reduction in heart failure hospitalizations. But again, my friends, here we go again. Heart failure hospitalizations represented only 7% of total hospitalizations. There were no differences in total hospitalizations. Now, the authors of the 2 trials have already done one pooled estimate. This was European Heart Journal published a combined analysis of 6,500 patients in each group, and that found modest reductions in both cardiac and renal composites. Now, the big point from this meta-analysis was the mixture in baseline GFRs. Nearly all had greater than 25 GFR, but also the urinary albumin to creatinine ratio. The authors called this pooled analysis fidelity. And the urine albumin creatinine ratio was the talking point. So first, we have to identify Finerenone eligible patients. Now, CKD was an entry criteria for these trials, and it was defined using the GFR and urinary albumin creatinine ratio. Either you had to have increased albuminuria with an eGFR between 25 per 90, or you had to have severely increased albuminuria and a GFR greater than 60. So the results of the pooled analysis were the same as the original trials. A modest, less than 2% absolute risk reduction in the combined CV endpoint of CV death, MI, stroke, and heart failure hospitalizations. And again, it was driven by this small reduction in heart failure hospitalizations, was still less than 10% of the total hospitalizations. So the new analysis in JACC was similar, but this time they looked at slightly different endpoints. Say, CV death and first heart failure hospitalization, or recurrent heart failure hospitalizations, and CV death and recurrent heart failure hospitalizations. And of course, they're all positive because they all contain heart failure hospitalizations. They then looked at heart failure-related effects of Finerenone on subgroups by GFR and by albuminuria, and the modest effects of Finerenone look similar in all categories of eGFR and urinary albumin creatinine ratio. Now, the authors note there's early separations occurred, and they cite this as a reason to use the drug early. They also spend a few hundred words in the discussion speculating on mechanisms of heart failure hospitalization reductions, and I can actually do it in 4 words. Finerenone is a diuretic. My friends, if Finerenone was superior to spironolactone, a drug with huge effects in patients with heart failure, especially reduced ejection fraction, and probably beneficial effects in patients with preserved ejection fraction, say TopCat, we would then have to discuss cost efficacy. Proponents of finerenone would say, I'm comparing different patients, and so I get that, it's true, but my point is merely that spironolactone is a highly, highly effective drug. And these pooled analyses, especially the one with post hoc endpoints, led to publications in big journals, and there's plenty of charts. These are going to make great PowerPoint presentations for drug reps to show unsuspecting doctors, but they do nothing to change the fact that finerenone may be a very costly diuretic that may be either no better than or marginally better than spironolactone. Okay, final topic, perceptions of cardiology. JAMA Cardiology has published a paper, a survey of internal medicine residents looking at their professional preferences and perceptions of cardiology. First author, Dr. Megan York. The survey of 840 internal medicine residents had two neat twists. First, they could compare answers of this survey with those of 2010. And second, there were near equal numbers of males and females, and I find that really cool. Now, using the 1 to 5 Likert scale, not important to extremely important, residents rated 38 professional development preferences, things like stable hours, positive role models, finance, professional challenges, etc. And 20 cardiology perceptions, like CV role models, compensation, adverse job conditions, and fellowships, etc. The findings of this survey were interesting. The most important professional development preferences by descending Likert score were as follows: positive role model, stimulating career, and family friendly. The cardiology perception statements with the highest agreement were interferes with family life during training, having met positive role models, and having positive views of cardiovascular disease as a topic. Now, the authors then did a correlation or multivariable analysis of factors that would predict choosing cardiology as a career choice. And compared with the 2010 survey, the findings of this survey indicated increased importance of work-life balance components for both male and female residents, with a greater change in male residents. Contemporary residents were more likely than their predecessors to agree with negative perceptions of cardiology. Okay, comments. You might think this is a soft topic for an evidence translation podcast, but it really isn't. Heart disease is a leading killer of humans and leading cause of ill health, and we're going to need a well-trained, available, and empathic workforce. Now, first, it is a great thing that more women are coming into the field. As I've said, nearly half of my partners here in private practice are women. It's normal for us. But this also means systems must change. The old way is not going to work. For instance, not long ago, female cardiologists who got pregnant took extra call during pregnancy sometimes to make up for the call they would miss during maternity leave. This is egregious, atrocious, whatever word you want to know, and it has to change. Of the many things I've learned from visiting Europe relatively often is the practical way they approach training. For instance, trainees are paid a reasonable wage, and there's a generous family leave for children. In Denmark, it is expected that you will be done and have time for family each day. And I'll ask, well, wait, how do you give a physician mom 1 year maternity leave? And the answer is, well, John, we planned for it, because it's normal. Now, the trade-off is that training there may last longer, but that's not a major issue because of systems. That is, trainees are paid well and not overworked, so there's less rush to get out of training. Now, that young people in the U.S. increasingly emphasize work-life balance is a positive sign. As my friend Dr. Dennis Lau from Adelaide said, John, there is more to life than work. Again, systems can help, right? A positive development is the idea of hiring people to cover nights and weekends as their primary job, rather than having people share the burden of working 2 days straight without rest. The barrier in the U.S., of course, is that this costs money and might diminish profits. Okay, second point. I push back strongly against the notion that we must overwork young people to make good physicians. That said, the time in fellowship, when you're exposed to experienced clinicians, is absolutely crucial to learn the basics of cardiology. This is the time to focus on getting the foundation of being a doctor. Now, sure, you're going to keep learning and practice, lifelong learning for sure, but the exposure to experienced doctors is unmatched in training. Never waste it. After seeing a patient even this year, I often think back to IU and remember that is exactly what Eric Williams or Paul McHenry or Suzanne Noble taught me 25 years ago. And finally, a final comment on work-life balance, the work part. Some people think this ratio is simply about having a job that gets you out at 5 and requires no thought after the shift. I think that's short-sighted. No matter how good your work-life balance is, you will be at work a lot, and you want it to have meaning. Am I contributing to the greater good? And this is where cardiology, or doctoring in general, shines. Your job is to take people who ask for help and use your hard-won skills to help them, every patient, every day. This is what you do. You help people. Sometimes it's with a complex procedure, but more often it's just sitting down and listening and using words that heal. And seriously, I know that sounds banal, but so much of cardiology is about extracting fear. To me, the meaning part of work is underappreciated factor in work-life balance. Of course, you don't want to be run ragged, but what I love so much about cardiology is how our job is to help people who are sick and asking for our help. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating. Even a 1 or 2 sentence review goes a long way to helping others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.